Hello everyone and welcome to this NHS Providers webinar. We're joined by Chris Hopson, Chief Executive, and Saffron Cordery, Deputy Chief Executive of NHS Providers, and we're going to take you through where the NHS is now and how it moves forward to recover from the pandemic. Thank you and welcome, and over to Chris.
Okay, well, good afternoon, everybody. It's been a very busy few months for the NHS, but let's start off by reminding you who we are. The membership organisation for the 215 acute hospital, community, mental health and ambulance trusts. We're very pleased to say that we've got every single trust and foundation trust in membership. You'll hopefully remember that our members employ the vast majority of NHS staff. We've got they have a combined turnover of £92 billion, and we're an England-only organisation. And our members basically are providing care for about 1 million people every 36 hours. So basically, along with, as you remember, primary care, the sort of backbone of the NHS. So what I thought I'd do is just start off by just saying a little bit about what's gone on over the last 2 or 3 months. I think you all know the NHS has been under probably greatest pressure it's been under in its 72-year history. We saw, didn't we, a very significant second. Interestingly, I get pulled up by our chief execs when I do this. If you're in the south of England, it's the second phase, but the northern trusts are very clear that for them it was a third phase in terms of late December, January and February. So we've been particularly busy over that period. Perhaps what hasn't quite come across in some of the media coverage is there were places and times over that last couple of months where we were very, very close to being overwhelmed as a service. And there's an interesting debate about what does overwhelm mean. But just to give you a couple of examples, we know that, for example, in many acute hospitals, in order to deal with the volume of coronavirus patients that were coming through, we had in many cases to either double or triple the ordinary amount of intensive care capacity that those hospitals had. So that required us to, for example, use recovery areas, use operating theatres, even places that we don't normally use for clinical care. We were having to displace non-COVID patients into those areas so that we could use the better equipped ordinary areas for caring for clinical areas to care for people who had COVID. We had to deploy very large numbers of staff onto supporting those patients. And I think a point I particularly wanted to reinforce with you is just the point that quite often, for reasons we understand, much of the media coverage focuses on hospitals, but I think it's really important we understand how busy mental health, ambulance and community services trusts have been. So ambulances, for example, the London Ambulance Service was, again, very, very close to being overwhelmed. And it was only really, for example, thanks to the help of, for example, drivers from the Fire and Police Service that were helping to drive ambulances that really enabled the London Ambulance Service to keep its head above water. So if you add that along with the normal sort of winter pressures, you will see that the service has really been under, as I said, extraordinary amounts of pressure. I think the bit, again, you will hopefully have seen from the media is that what I think most worries our chief executives is the impact that that has had on our staff. And again, you'll remember from the dialogue we've all been having over the last 3 or 4 years, our argument has been that before we got into COVID-19, there was a mismatch between the NHS's demand and its capacity, and that therefore what had happened was that we were asking our staff to work harder and harder to close that gap. So our staff were already feeling under huge amounts of pressure, 100,000 vacancies before we went into COVID-19, and we'd been asking them to work harder and harder to close that gap. We then go into COVID. We've had a really, really difficult and busy year between March and December. And then what we've had to do on top is our staff to really, really go several extra miles in January and February. So there is a definite need, I think, for our staff to be able to recover and decompress. But I'll let Saffron talk in a bit more detail about what the forward kind of look looks like. But if you ask me about what is top of chief executives' agendas at the moment, it's that. I think more generally, and if you can put up the next slide, Kerry, that would be really helpful. Then I think, again, what I think our chief executives say is just that there's a real sense at the moment that there are a huge number of priorities that the NHS needs to face. And the real issue is how we prioritise between them, given that actually there is simply too much to do over the next few years, if you take a Parliament long view, for the resources and the staff and the financial resources that we have available. So what we're kind of tending to do at the moment is sort of divide it into 4 buckets. There's a clear need to continue the COVID-19 response. In terms of that, we know there will be ongoing operational pressures, mass vaccination campaigns, probably for each of the next, let's say, 5, 6, 7, 8 years. The Prime Minister has already identified there potentially is a next wave kind of coming. So we need to prepare for that. I mean, hopefully, because of the success of the vaccination campaign, the numbers and the severity of people who hospitals will need to treat will be less. And we obviously need to kind of learn the lessons and keep the best innovations. There's then a bucket of manifesto commitments that we know the government has committed to delivering, 40 new hospitals. Clearly, we need the social care reform. We've committed to expanding the workforce. There's then, as we've talked about, a significant amount of recovery that needs to be done in terms of supporting NHS staff to recover. But there is a very significant kind of waiting list backlog. We need to get back to normal finances. And certainly, again, one of the themes of the day, particularly of this week, has been the amount of new mental health demand that's been created. And if you're asking me about where the real pressure points in the service are at the moment, there's absolutely no doubt that acute need, mental health need for young people is a real problem at the moment, because we do not have enough capacity for inpatient beds for children and young people who have got the most acute needs. And then at the same time, we also need to deliver the long-term NHS plan, which you'll remember we agreed with the government in return for the extra investment. So a move to system working, focus on prevention, expanding community services and tackling health inequalities. So there's a real sense, I think, that as you kind of look forward, there is a huge amount to do. You will find that tomorrow, NHS England will be publishing its planning guidance for the next phase. So normally, as you probably know, the NHS gets its planning guidance in late December and then plans about what it's going to do in the following financial year. It tends to submit those plans in February, ready to start implementing from the 1st of April. Well, for reasons you'll perfectly understand in terms of the pandemic, then we're on a different timeline this year where effectively we've not been able to do those plans. So the guidance will be issued tomorrow. The plans will need to be back by early May. And at the moment, we're very deliberately working on a 6-month timeline. We're not working any longer than that because of the degrees of uncertainty in terms of what's happening with COVID. So NHS organisations and local systems will be asked to produce a plan for the following 6 months. And one of the issues will be about how do we balance, particularly that orange recovery box, about how do we balance the requirements there. So it's a very, very busy time for the NHS. In the words of a chief exec who I was talking to this afternoon, their concern was that it's been a very, very difficult last 12 months, but they actually thought, given the scale of what needs to be done here and some of the pressures that we're likely to experience, their view was they thought that the next 12 months was going to be just as, if not more difficult than the last 12 months, in a very different way, because clearly you won't have, hopefully, the kind of focusing single objective of getting through the pandemic. But their argument was this range of objectives to achieve is very, very challenging. So that's where I think we're kind of up to from my perspective.
Okay, so just a few words from me, because it's probably best we get into some of the questions from you. I think absolutely we talk about this concept of new normal, but I think really what we are talking about is how we're going to embark on a health service post-pandemic. And actually it's probably there is much that has changed during the course of the pandemic. So I think the transformation element the positives that we can take from the pandemic are really important, as well as reflecting and remembering what difficulties the NHS and the country have been through indeed, and also are continuing to go through. So I would say that there have been huge transformations that we have seen, particularly around things like digital transformation. And we shouldn't forget how the NHS literally pivoted and became not a wholly digital service, but managed a significant degree of digital transformation overnight in order to be able to continue to run its services in a way that was safe and appropriate for a pandemic setting. I think the other thing we have to remember is that the way that our workforce has transformed is quite astonishing. So we have seen huge flexibilities out there from across every specialty in the NHS, turning their hands to very different roles, working in very different ways, working flexibly, coming together with colleagues and discovering skills that they didn't know they had, that the organisation that they work in can now hold on to and capture. So I think there have been some real positives that I think it's worth remembering in all of this, because if we are to motivate our workforce to go forward in terms of taking the NHS in a direction where it comes out of the pandemic and starts to deliver services and also starts to make some inroads into that backlog, then we do have to think really carefully about how we boost their morale, how we keep them focused, motivated and hopeful. Some of that comes from pay, some of that comes from having enough staff on the front line, but it also comes from having a hopeful vision of where the NHS will be over the next year, the next 5 years and into the future. I think my last word will be on mental health, which has kind of flown a little under the radar compared to other bits of the NHS during this pandemic. We've talked a lot about the health and the mental health and well-being needs of NHS staff, and they are front and central. But I think what we have to remember is that the demand for NHS services has grown exponentially, and in particular, Chris mentioned this, but I think it's worth reinforcing, children and adolescent mental health services have really suffered during the pandemic. Children's services overall, we know in community services, they were nearly all wound down in order to support the pandemic on the acute front line and to support discharge of adults. We really need to focus on making sure that children and young people aren't the kind of forgotten victims of a lot of what went on in the pandemic, given how they have suffered and struggled during this. So I'm going to stop there because it's really about having time for questions.
Thank you both. Just before we move on to questions, so attendees, if you feel free to put them in the chat box or raise your hand. I just wanted to ask you what you thought the number one priority should be for the NHS over the next 6 months. Obviously, you've touched on workforce and you've touched on the sort of COVID recovery. And I just wondered, what do you think is the number one priority for our members over the next 6 months?
I think it's a really good question. And I'll tell you what I'm frightened of. I'm frightened of the idea that we put the staff needs for recovery into direct conflict with the need to start recovering care backlogs. And I think there's a massive bear pit trap for the NHS of effectively, if we start saying publicly too loudly and clearly, our staff must come first, they must be allowed to recover and decompress, which, to be frank, is the top priority for me. I'm really clear about that as our chief execs. But if that ends up being in conflict and people start saying, hold on a second, we pay for the service, how come you're not recovering these care backlogs more quickly because you're allowing people to have some time off, then I think that, to be frank, is a very, very difficult narrative. But I think talking to our colleagues at NHS England and Improvement, I think the way they describe it is you can't provide the care that you need to unless you have a staff workforce that is capable of doing that. And if you've got you know, as we've been having at various points, you know, 10, 15%, 20% of your workforce off ill, or to be frank, those people kind of choose to actually leave the service permanently, then whatever your ambitions might be to recover care backlogs, if you can't get that right, then that's, you know, that's a real problem. And I think the thing that I would particularly say is that, again, our lovely media is very good, and to be frank, we're quite good at kind of sort of simplifying and boiling things down to, you know, recovery and decompression. What's really interesting when you talk to chief executives is the wide diversity of need out there. So the thing that brought it home for me was a conversation with the chief exec about 3 or 4 weeks ago, who said, look, I've got a bunch of orthopedic surgeons over here who are desperate to get back to doing what they love doing, which is operating on people. Because the theatres have been closed, we've had them doing vaccination campaigns and they've really, really enjoyed it. But actually, they just want to get back to doing their job. And then over here, we've got some, to be frank, people who we asked to go and do the most difficult jobs in intensive care being supported the best we could by intensive care doctors and intensive care nurses, but who, to be frank, have seen and had to deal with some really incredibly difficult things. And they are, let's be really clear about it, traumatized. And what we need to do is we need to work with them really intensively to give them some space to decompress, but also give them some really quite sophisticated and individualized and bespoke mental health support to enable them to kind of get over and to kind of, you know, be able to kind of fully go back to you know, what we need them to do. So I thought for me, that sense of, and you know, there are multiple poles here, and I wouldn't want to sort of say that there's a spectrum and that's at one end, that's at the other. But I just thought what that really brought home for me is the fact that, in a sense, each individual member of the NHS staff, but certainly those different groups have got very, very different needs. And the complexity of the leadership task at the moment on the front line is to work out how do you enable that recovery to kind of take place in an appropriate way. So, you know, Trust I was talking to yesterday has had a really brilliant, they said, you know, recovery fortnight, where over the last 2 weeks, they've deliberately really focused on enabling and supporting their staff to recover. But, you know, that's the key task for me, is to really work out how do we enable our workforce to get to the place where they can really you know, provide the quality of care and start tackling those care backlogs that we need. Because if we don't get that right, we won't be able to do anything else. I don't know whether you agree, Saffron.
I do agree with that. I suppose my priority, if I were take a step back and look at this, I think the number one priority for the NHS is tackling health inequalities. They have, you know, nothing has lifted the lid on health inequalities quite like a pandemic, and we have seen front and central the impact of COVID on Black and minority ethnic staff, in particular at the front line, but communities more broadly. And I think that it has demonstrated to us the extent to which, as an NHS, as providers, and as parts of the public sector, we really need to grapple with the impact of health inequalities in everything that we do. And that's not simply, I say that in inverted commas, that's not simply in terms of equality and diversity initiatives in the workplace. It's about how do we look at things like waiting lists? How do we look at different elements of service provision? What does it mean to be from a Black and minority ethnic community trying to access a mental health service? There are all sorts of issues here that have really come to the fore, and we will be doing everyone a disservice if we overlook them.
One very quick addition, Kerry, is what's really interesting about the service at the moment is that if Matt Hancock was sitting here and if Simon Stevens were sitting here, I'm 90% certain the answer they would have given you would be vaccination campaign. And what's really interesting, as I said, is that real sense of, that's why we did that slide right at the beginning, is to just show you that this is an incredibly difficult environment for the NHS, because we've got lots and lots of different things that we really must do and must do them quickly. And that is part of the challenge here, is really about how do you prioritise between them when they're all incredibly important.
Thank you both. Karen Smith has got a question.
Hello both.
Karen,
and you. I've just come literally. I've just hot-footed from my chair from the RCN. Did a regional briefing for local MPs with staff, and on that call, the sheer exhaustion, frustration, demoralisation was really, really apparent. And now I know we've talked about this, and we've met as local MPs in Bristol, 4 Labour MPs, every fortnight with our CCG leaders and others. So we have had very good updates all the way through. There's nothing quite like hearing from those people, some of them who are shielding and have moved around the system, to one juggling a child on her lap, one who couldn't get vaccination from a GP centre. I'm really not clear how that happens. To get the real sense of how bad it is. And I know you both talked about this very strongly over the last few weeks. I think you're right to highlight it. What struck me then is, and people did talk about it, is that how on earth are they going to get a break and other people come in to help the recovery, which will be the most crucial thing. And so I guess I completely agree, Chris, that managing that possible conflict between really where the service is, and I don't think I've ever seen anything like it in my time working in and out of the service, in terms of physical and mental exhaustion of staff and traumatized staff, and the need to recover. And what I said to them is, we're all human beings, aren't we? So many, if you haven't lost someone yourself or seen someone, you're struggling at home with your family, and so they enter it as human beings as well as traumatized staff. I wanted to ask about the vaccination stuff, because I think in terms of the health inequalities angle, so that's the first thing, totally agree, massive problem, probably even more massive than I appreciated. In terms of the vaccination issue, the other thing that struck me, that we've got the data now on where the disease is, how endemic it is in poorer communities, which I have in my constituency. That's the community from which we recruit, particularly for care and healthcare assistance. So we're in a vicious circle, aren't we? With the disease is most prevalent, it is becoming endemic in an area where vaccination rates are lowest, and then those same people needing jobs to keep themselves going, many whom work in the care and health sector. And I just wonder if you want to say something about vaccinations and the approach to that, both across, I know you represent the trusts and so on, but I don't separate that care system, because the thing about the non-vaccination of care workers, it's going to clog up the system. I don't like bed blockers, but people are not going to discharge their families into settings if they are not sure that they are as 100% safe as possible. So that starts to create more problems for you in the rest of the healthcare system.
I think that, you raised some really, really important points there, Karen. And I think this whole issue, I was talking about it earlier, actually recording a podcast around workforce with a couple of our chief executives. And I do think the whole issue around one, the interdependency between health and social care is absolutely there. And so, the success of one, it depends on the success of the other, and when one bit of the workforce is depleted, so it impacts the other bit of the workforce. So you're absolutely right there, and we shouldn't divide them out. And I think it's more the architecture of government and the machinery of government that divides them out as much as anything else, because they are one care workforce. I think how they are treated is incredibly divided. I think we've got a big job on our hands, actually, in terms of overcoming issues like vaccine hesitancy in particular. And I think this is a difficult one to broach and to talk about, but there are moves afoot potentially for things like mandated vaccines for care staff, and I think it's something we need to think really carefully about because of the ethical issues around that. And it's actually, how do we have the right conversations with staff to encourage them to have the vaccine and make sure that there is full access to the vaccine, rather than going down this mandation route, which, particularly if they haven't signed a contract that says those particular vaccines are mandated is a very difficult route to go down. I think that the point you make about staff being employed from the same communities who are most hit by COVID is also very powerful. And I think that, I think it comes back to my health inequalities point, where we do need to think really carefully about how we can really support staff from BAME communities, from other communities who are really struggling, to make sure that they get the access to vaccines and the access that they need, rather than us assuming that a single blanket approach will really work. I'm going to stop there and hand over to Chris.
Yeah, I think, Karen, you're right to identify that the whole issue around vaccine access and vaccine hesitancy and mandation is really come to the fore over the last 2 or 3 weeks. I think I've said to you before that our life is really easy when we have a single view across our members. It gets much more complicated when there are different views. And this is one where genuinely there are different views. Some people whose view I really respect were very clear with me the other day when they said, look, we require our frontline clinicians to have hepatitis B vaccinations, because effectively there is a kind of safety risk to patients that they deal with if they haven't had that vaccination. What's different about COVID-19? And I thought, yeah, I get strong argument. Then the next day I had a completely different conversation with somebody who argued to me really passionately that effectively, if you really delve into what's going on with vaccine hesitancy and how you overcome it, it's very, very clear, and this is a pretty consistent story, that the best way to deal with it is to have supportive individual conversations with those who are hesitant and really take them through on an evidence-based basis, really explore what their concerns are, and then actually what you find is that, and this is, by the way, goes not just for staff, but it also goes for patients, that actually that seems to be the best way of overcoming that hesitancy. And the argument they then went on with was that, particularly with staff, the absolute worst thing that you could do would be to bring an element of compulsion into it, where you have to do it, because their view was that staff will kind of take against it. What I'd then overlay that with is there is a particular problem at the moment, which I think has really come out, which is there is very, very different vaccination rates between care home staff and between NHS staff. And we know these discussions have been going on about there are a significant number of people who feel, for all the reasons we know, that it would be inappropriate to mandate care home staff without having a similar mandation approach for NHS staff. But the NHS argument is that we're up, I think, at 95% in terms of kind of overall take up. And the NHS view is, in most places, and I think this is probably, it's fair to say it's a majority view, is that the best way to tackle the remaining 5% is don't go the mandation route, but actually kind of go the persuasion route. And there's a nervousness that, recognizing that care home staff percentages are much lower, that, just rowing the NHS in because there's a care home staff problem or care home staff issue feels uncomfortable. So I think this is clearly going to play out, it seems to us, over the next probably, I would guess, kind of couple of weeks. But as I said, it feels complicated because there's a wide range of issues involved. In terms of your point about staff being absolutely exhausted and how are we actually going to enable them to recover, that is the task that our chief execs are currently kind of grappling with. And it's one of the reasons as to why we've said very clearly, be very careful about how rapidly we seek to impose a very aggressive target in terms of recovery of, for example, elective surgery volumes, where if the only way of doing that is to require our staff to work at another 110 miles an hour for another 2 or 3 months, then actually you really do risk breaking the machine. So, but clearly, as I said before, that's not an argument that I think, it's a difficult argument for the NHS to run. So what each individual chief exec is doing with their exec teams is really working out what does a sensible pattern, and particularly a pattern that takes account of those individual needs and those group needs, look like in each trust. Because the other issue is that each trust is at a different place in relation to where it starts from and what's been going on inside that trust. But that is literally what each individual organisation is doing at the moment. And, as you might expect, there is a degree of variation for local circumstances. And as I said, I was very struck by how the chief exec I spoke to yesterday was how well their recovery fortnight had gone, and actually it had made a real difference. So it will vary from place to place. But your basic point that the staff are absolutely exhausted is spot on. And I'm struck that when you talk to people, particularly frontline people, you can see it in their faces, you can see it in the language they use, you can see it in terms of just how absolutely dog-tired they are.
Thank you both. Karen, did you want to come back in on any of that?
No, enough from me. But no, I'm absolutely right. You can see it in their faces. I think that's a very good way to describe it. Thank you.
Thank you. Just while we wait for some other questions to come in from the audience, as the lockdown is being eased, have you had conversations with your members about what they're most concerned about? Are they worried about this potential third or fourth wave coming through from Europe? Are they still kind of keen to keep some of the restrictions in place as the vaccination programme is rolled out?
Well, I think hopefully colleagues will have seen some of the arguments we've been making all along. We've been deliberately taking a kind of cautious approach, and we specifically said that what we wanted to see was a progressive relaxation based on the data, not the dates. And we set 4 tests, which weren't exactly the same as the government's, but were in the same broad area. And then we also felt very strongly that we wanted to adopt this approach of relax a bit, see what happens, leave it 4 or 5 weeks, then go on to the next relaxation. And we're very clear that is an appropriately cautious approach. And, it is interesting, as soon as we have, ease the lockdown, you are starting to see the infection rates in certain parts of the country haven't just kind of, plateaued, then some places they are now starting to rise. That's not a great surprise, it seems to us, which is it's what you would have expected as you release the lockdown measures. Clearly, what we're all relying on is the fact that the vaccination campaign, particularly groups 1 to 9, eliminate 99% of the mortality risk, or should, in theory, if the vaccines have got full efficacy, should it eliminate 99% of the mortality risk. And then also, I think I'm right in saying it's something like 95% of the hospitalisation rate risk. So although we are seeing the infection rates rise, the hope is that doesn't translate into hospitalisations. The kicker that none of us really fully understand yet, and hey, I'm slightly now going beyond the edge of my envelope, and I always say that of expertise, look at Saffron's face, is that we still don't know exactly how effective these vaccines are in relation to, foreign new mutated variants like the Brazil variant, like the South African variant. So if you ask what are our members concerned about, what our members would be concerned about would be if the South African variant were to kind of come over to this country in very large numbers, and were it to kind of go through the population at the kind of speed with which the Kent variant went through, And if it turned out, as I understand, there is a risk that actually, for example, the AZ vaccine, which, for example, has been the one that's been used in care homes a lot, if it turned out that that vaccine was not as efficacious in relation to those variants, then potentially that's the bit that I think people would be really concerned about. And there is still no definitive evidence yet, as I understand it, that demonstrates that you're getting 99% mortality protection, 95% hospitalization protection against those foreign variants. So that's the bit where I think, there is a concern about where the risk might be. And just to make the point, Kerry, is that, for quite understandable reasons, and we'd be in the same place, people really want us to get a move on with recovering those care backlogs. But as soon as you get any significant amount of hospitalization rate, then effectively, by definition, that will affect our ability to be able to carry on with that elective surgery backlog recovery. So one of the questions that I think we really do need to ask ourselves is, what risk should we be looking to manage going forward? And I don't think anybody in the NHS would say, look, you need to be ready to deal with a wave of the size that we've just seen over the last 2 or 3 months. But presumably you'd have to say that because of the risk of, for example, those foreign mutating variants, you do want the NHS to have the capacity to deal with, let's say, a wave that's a quarter of the size that you've seen over the last 3 months, and be able to carry on doing that elective surgery backlog recovery, be it in July, be it in October, be it in November. The bit I think is really interesting is you've got Chris Whitty saying, you've got the Chief Exec of the ONS saying, you've even got the Prime Minister now saying that some sense of third wave is absolutely, or fourth wave, is absolutely inevitable. So the obvious question, it feels to me, is, given we're all going to be saying, carry on recovering elective, how do we need to configure the NHS to ensure that if we do get that smaller wave, we can carry on doing the elective surgery recovery bit? And I can promise you the NHS is not currently configured to do that at the moment. There are some more things that we would need to do to ensure that happens. Sorry, Saffron, as ever, I've gone on too long.
No, don't worry. I've got nothing to add to that. That was a very comprehensive answer.
Thank you.
Thanks, Chris. So we've got one question from Baroness Masham, and then we'll come to Baroness Finlay.
It's Sue Massam here. I wanted to ask you about intensive care beds. We just haven't got enough, even before Corona. We have so few compared to Germany, and people won't be able to do the backlog of operations until they have more intensive care beds. That's always held up. So what are we going to do about getting more trained staff?
I think you're absolutely right that this was an issue pre-pandemic. I think it's come to the fore during the pandemic, and we know that critical care capacity is fundamental. I mean, it's absolutely fundamental, of course, with coronavirus, but it is also fundamental if we are to manage to clear the backlog. And I think sometimes we say that comparisons with other countries aren't helpful, but I think in this one it's particularly helpful to highlight the kind of per capita ratios that exist in certain European countries compared to ours, because we are particularly short-bedded in that sense, and that capacity is fundamental, and has, I think the last year has shown us how fundamental it is. So you're absolutely right.
Yeah, and Sue, hopefully, good to see you, by the way. Thank you for joining us. Hopefully you might have seen that about 3 or 4 weeks ago, it was a front page Guardian story where we called for a formal review of critical care beds, and basically said that we thought it needed to do 3 things. One is, how many beds do we need overall? How many do we need in each region? Because it's very clear to us that there is a regional disparity, particularly the southeast and the southwest seem to us to be under critical care bedded. And then the third issue was what's the right distribution within regions? Because we know there is, in some senses, an understandable move towards trying to create more critical care hubs. But what you do need to ensure that is across particularly large geographical regions, there's an appropriate spread. And I'm very glad, Sue, that you talked about also about staff, because when we talk about beds, we quite often can fall into the trap of thinking about just capacity, bed capacity, as opposed to the staff that go with it. And again, one of the really interesting questions to ask yourself is, where are the pinch points at the moment? And when we talk to chief execs, the two pinch points that for me come out the most, or three that come out the most, is one at the moment is diagnostic capacity. The second is anaesthetist capacity. But the third is definitely ICU nurse capacity. There's a very clear view that if we want to be able to successfully navigate a third/fourth phase, even if it is half or quarter of what we've just been through, we don't have enough intensive care unit nurse capacity. Clearly, there's an interesting question, and if that is the case, is how do you solve it? But you're definitely, if you're asking, should you be raising this in the House of Lords as a big issue, we would encourage more power to your elbow. You're absolutely on the right track there, because it is a big issue. And we'd love to see government making a commitment that it would formally review the number of critical care beds and attached staff.
Baroness Finlay question has also kind of been answered by that, but did you want to add anything else?
Well, it has only partly, because before the pandemic, the backlog in emergency departments was getting worse. The flow through the departments had not happened. And if looking at their monthly data, it's getting worse again already. That we know that the departments are far too small for the amount of workload that comes their way. There are different models being proposed, but something radical really has to happen. And that means a radical shift in 24/7 cover out in the community, because crises in the community are getting shunted, particularly out of hours, into ED. They're just being shunted down the road. And that doesn't help anybody. And without better 24/7 cover, this backlog is going to build up. The staff in the ED departments are also completely on their knees, and completely, I mean, beyond belief on their knees. And also, if this keeps rising and these departments are crowded, the infection risk just goes up and up and up. And in terms of trying to keep the infection risk down, relatives are being kept out. And yet the relatives sometimes need to be with them to accompany the patient, get them drinks while they're waiting, keep them calm, and so on. So, in fact, the isolation policy is rebounding.
I think, Laura, am I right in saying, I'm right in saying, aren't I think that you're a great champion of the Royal College of Emergency Medicine? Do I have that right?
You do, and I declare an interest now because my daughter's clinical lead now for emergency medicine at St Mary's, so I see it from both ends of the telescope. Great.
Well, no, and I think it's a really, really important issue, and it's something we've been talking to Catherine Henderson at RCEM about for quite a long time. And you're right, there are a fundamental set of issues in emergency care, on the emergency care pathway, that we need to address. So I think, as you know, what we've been trying to do to address some of these issues is exactly as you say, is to do 111, telephone triage up front, to then try and do direct patients who don't necessarily have to go to emergency departments into other parts of the community, into other services, using a directory of services that can be used by a 111 telephone call handler to direct people into a different place. Then you're absolutely right. We need to look at how do we ensure that departments are safe, they've got the right size, and they've also got the right infection control measures. We also know, exactly as you've said, that we're short of staff. And I think if I'm honest, one of the things I know Catherine is worried about is that effectively that what will happen is that because the focus will inevitably shift to elective surgery recovery, that there'll be a lack of focus on that emergency care pathway, which I think would be really, really unfortunate, because you can just see that, particularly given the point at which the volumes that you normally see going through that pathway start going back to where they would normally be, we will really, really struggle if we haven't reconfigured that pathway to ensure that other bits of, to ensure that those patients who can be looked after system are looked after. Again, Catherine was very interesting the last time I spoke to her, and indeed I think I saw her in the media today saying this, is that one of her concerns is that at the moment we are seeing too much mental health crisis demand that is coming along to accident and emergency departments. And she was saying, in particular, it's one of the things that really brought my children and adolescent mental health crisis services top of my mind, was she was saying that at the moment, because there's insufficient capacity, they were literally having people, young people in real distress, who were having to spend up to, and gulp, 3 to 4 days inside a department before they can get access to appropriate services. So your basic point that there's a real danger that A&E departments end up being the place of last resort, and effectively, if other bits of the system aren't working effectively, that's where those patients end up, even though it's completely inappropriate. That is a real problem. And until we can get the system properly configured to, for example, deal with those kind of patients, then there's a real danger that's what happens. Saffron, I'm sure you'll want to come in as well.
Well, I was going to raise that mental health point. I think that it's not just about the demand that's coming from the community services. It's also that demand from mental health. And we know that particularly, we mentioned children and young people, but we know that it's particularly intense for children and young people, and the provision, in technical parlance, the tier 4 provision, so the most intensive support for children and young people, just isn't being commissioned to, the capacity isn't there, and it's not being commissioned to be there. And so that causes huge knock-on problems. In fact, I was talking to a chief executive today who was from an acute trust, who was really worried about the impact on young people being treated either in inappropriate settings or having to be discharged to other settings hundreds of miles away from home in order to get the appropriate treatment. It's stuff that we saw before the pandemic, but it's kind of coming back in sackloads. Yeah. So it's very, very challenging.
Can I just follow on slightly from that? And because of the out of hours issue, we don't have 7-day services even. And it's crazy. And yet we've learned through the pandemic that we really do need 24/7. 7 days at least will be part of the way. And many of these young people have crises out of hours. Their whole biology is not working 9 to 5. And so their crises are happening in the evenings, at weekends, and then nobody knows where to go. And it actually escalates. So even the crisis that's beginning, it isn't being intervened on early to stop it escalating.
I think that I'm going to go. I think on this, I think this speaks. You're absolutely right. You're absolutely right. But this speaks to the level of demand that there is out there, because we know that at the beginning of the pandemic, that some with some very fleet of foot work, there were more 24/7 mental health services put in place, for example. I know you're not just talking about mental health services, but they were put in place, but the demand far outstrips what has been put in place. And that's why we are seeing so much more now coming back in to A&E departments out of hours than we have seen.
Yeah. I think, Laura, I'd say two things. For me, there's two issues. One of which is some of it is clearly about capacity, in terms of we just simply don't have enough workforce and enough capacity to make it 24/7 services, some of the services that need that. If I'm honest, and I think it's always important to be self-critical and on an improvement journey, I still think that too much of the NHS is run for the benefit of those who work in the NHS and isn't configured for the needs of patients. And a very good example would be just the overall prevalence of, it being a Monday to Friday 9 to 5 service too much in too many places, whereas exactly as you say, there are many, if not vast majority of kind of services where people are ill 24/7 and that actually therefore need appropriate provision. So I think both of those are things that we need to solve. And one of the things, in a shameless plug, that we will hope to be talking to you about when the bill comes in front of you is effectively we're working towards the idea of giving the Secretary of State a duty to ensure that he sets out, or she sets out very clearly on a regular basis, how big an NHS workforce we need, what shape and what size, so that effectively there can be no debate and no argument about what the NHS needs are, because it's very clear to us that our colleagues in the Treasury and at Number 10 have consistently vetoed the idea of the NHS putting out such a plan for fear of the public expenditure consequences. And it seems to us we need a clearly established plan of what workforce numbers the NHS will need and what shape of workforce it needs in order for us all to be clear about, to provide the care that's required. And if you don't produce that plan, then what happens is that, the existing staff get asked to do more and more and more, and we try and cover that capacity workload gap in that way, when what we should be clear about is what actually does the NHS need in terms of numbers of staff. So that's a duty that we're sort of working on at the moment with colleagues, and we will hopefully be coming to colleagues in the Lords to talk about what kind of duty you might want to consider adding to the bill.
Thank you.
Thank you both. I think that's probably about all we've got time for. So I just want to say thank you to everyone for joining us and the questions. I hope you found this a useful discussion. If there are any other topics that you would find useful to hear about, do let us know. We'll be running more of these as and when they're needed. So thank you again, and hope to see you again soon.
Thank you, everybody.